accompanied weight loss, and this happens in people with type 2 diabetes mellitus. And as I say, I think these features are mostly true, but not completely true, and we'll talk a bit more about that. So, questions that we had in regards to this syndrome are, what are the characteristic features? Is this solely a proximal neuropathy? Is this solely a motor neuropathy? What is the pathological basis of the condition? And are there potential treatments? So we prospectively studied 33 patients with subacute onset lower limb pain or weakness not due to another cause. All had distal cutaneous nerve biopsy taken. We compared these patients to patients from a Rochester Diabetic Neuropathy cohort study. That is community diabetic patients with and without neuropathy to try to understand how common neuropathy is in a community diabetic cohort. We compared nerve biopsies of 33 diabetic lumbosacral plexus neuropathy nerves to 21 nerves from diabetic polyneuropathy and to 14 healthy people. All right, so what did we find? When compared to the community diabetic cohort, the age of the diabetic lumbosacral plexopathy was similar. They'd been diabetic for a shorter period of time. They had better glucose control. They had better glycemic control and more weight loss. And so one of the thinking of this condition for a possible pathophysiology has been that maybe this is due to glycemic dysregulation, but in fact they have less glycemic dysregulation than community diabetics do. Similarly, they have less complications of diabetes than community diabetics do. They are more frequently type 2 diabetics. They use less insulin. They have less retinopathy. They have less nephropathy. And so the typical complications from diabetes are less common in people who get diabetic lumbosacral plexopathy than in community diabetics. What are the different symptoms patients get with this? All of the patients in our series had pain, all of them had weakness, and almost all of them had prickling, and these involved the leg and the thigh. The syndrome begins with pain. By the time they come for evaluation, weakness is the biggest problem, and over the long term, weakness remains the biggest problem. This is not just a proximal neuropathy, although the thigh was the most common anatomical localization of this. The leg also was commonly involved. By the time of evaluation, this pattern remained the same, and long term, the leg tended to be the most significantly involved. And I think that's because reinnervation occurs better in proximal nerve segments, and so people may be left with foot drop or their thigh weakness resolves. This syndrome begins unilaterally. 29 of our 33 patients had unilateral onset, but by time of evaluation, it became bilateral. When we saw them, 32 of the 33 patients had unilateral disease. This is not a benign condition. Half of our patients were in wheelchairs, and all but 3 needed some gait aid to walk. Now, it's probably true that at the Mayo Clinic we were seeing more severe cases of this than might be the average typical case, but nonetheless, this condition causes a lot of morbidity and a lot of need for gait aids. Now, patients improved over time. Long-term, only 3 of the patients remained in wheelchairs, but many of them needed ongoing ankle-foot orthoses, canes, and so most of the patients needed some sort of gait aid long-term. So the idea that there's complete recovery in this condition is not true for most patients. The neuropathy impairment score is a measure of impairment summating weakness, reflex loss, and sensory loss. The average NIS for this group was 43, and for a focal lower limb neuropathy, that's a fairly high number. Most of this involved the lower limb, and the thigh and the leg were both involved in that. So again, it's not just a proximal neuropathy. Nerve conduction studies showed that the amplitude of responses were the most affected, but there was some slowing of the conduction velocities as well, suggesting that it's predominantly an axonal process. Needle examination had fibrillation potentials, large motor units, and multiple levels innervated by different lumbosacral roots. Fibrillation potentials were seen in 29 of 30 lumbosacral paraspinal muscles. Quantitative and autonomic testing were abnormal, so this is not just a motor neuropathy. Vibration was normal, cooling was normal, heat pain was normal. Similarly, pseudomotor, adrenergic, and cardiovascular indices were abnormal, and the total CAS score of 7 indicates a severe autonomic neuropathy in most of these patients. So this is not purely a motor neuropathy. Sensory fibers and autonomic fibers are involved in this. What did the pathology show us? It showed us evidence of ischemic injury. There was multifocal fiber loss, perineural thickening, perineural degeneration, new vessel formation, injury neuroma. And when we compared these nerves to nerves of diabetic polyneuropathy, there was significantly more ischemic injury in the nerves of diabetic lumbosacral plexopathy than in the nerves of diabetic polyneuropathy. And here are some examples. This is a low-power sural nerve from a patient with diabetic lumbosacral plexopathy that shows multifocal fiber loss. This fascicle is devoid of fibers, that fascicle is devoid of fibers, this fascicle is devoid of fibers, and there are more fibers in some of these other fascicles. Here is a higher power nerve biopsy from another patient with diabetic lumbosacral plexopathy, and this is quite informative. This fascicle doesn't have any fibers. One can see injury neuroma with all these little microfascicles here, and they have no fibers remaining. So the nerve was damaged. It tried to repair itself. It was damaged again, and you can see the damage continues, and there are many active degenerating fibers over in this other fascicle. So this implies multiple different ischemic attacks on this nerve. This biopsy is a paraffin section showing thickening of the perineurium. There's marked thickening of the perineurium, and this occurs in a focal way. You look at the perineurium of this, and it's not thickened. And so, again, this is evidence of ischemic injury. This paraffin section shows some fibrinoid degeneration of the perineurium. The perineurium is subject to ischemic injury. There's neovascularization. There are all these little vessels over here, and there's an inflammatory infiltrate into this vessel wall. So we saw all this ischemic injury. What was the cause of the ischemic injury? It seemed that there was an inflammatory attack on nerve blood vessels. We had small, moderate, and large collections of inflammatory cells in the diabetic lumbosacral plexopathy nerves, and this was much more increased than it was in diabetic polyneuropathy nerves. In half the cases, there was inflammation involving the vessel walls. In some cases, it was diagnostic of microvasculitis. In 2/3 of the cases, there was associated hemosiderin with some prior bleeding in the nerves of diabetic lumbosacral plexopathy, and that was not found in diabetic polyneuropathy. So here's an example of this microvasculitis. This is all one vessel. This row here is a level where it's not involved. The row down here is a level where the vasculitis is occurring, and you can see fragmentation of the smooth muscle actin seen in this vessel down here. So diabetic lumbosacral radicular plexus neuropathy is a subacute, painful neuropathy beginning unilaterally in the leg or in the thigh, but over time it progresses to become widespread and bilateral. This is not just a proximal motor neuropathy. Sensory and autonomic fibers are involved. Ischemic injury best explains the clinical and the pathological findings. The cause of the ischemic injury is altered immunity and microvasculitis. Because of this, we decided to do a controlled trial with IV methylprednisolone in diabetic lumbosacral plexopathy. So it was a multi-centered study. There were 4 centered. It was double-blind, randomized, placebo-controlled, intent-to-treat analysis. Our primary endpoint was the time to improvement to the neuropathy impairment score by 4 points, And as I've told you, the NIS is a summation of muscle weakness, reflex loss, and sensory loss. So there were two treatment arms. 2/3 of patients got IV methylprednisolone, 1/3 got saline. The IV methylprednisolone was started at a dose of 1 gram and was weaned to 250 milligrams. There were 15 treatments given over 12 weeks. Patients were evaluated intermittently over a 2-year time. We also had an IVIG arm, but this was discontinued because there was a shortage of IVIG and we couldn't get the drug. So 75 patients were enrolled, 44 men, 31 women. The mean age was 65 years. There was an improvement in the impairment in both the methylprednisolone and the placebo groups during the first year. So at baseline, both the IV methylprednisolone and the saline group had an NIS in the mid-30s. After 1 year, that score had improved to the low 20s, and that showed a significant improvement for both groups. This confirms the observation that diabetic lumbosacral plexopathy is a monophasic illness. The primary outcome, time to improvement of the NIS lower limb by 4 points, was not significantly different using Cox regression analysis. So we didn't show a difference in the time to improvement, even though the IV methylprednisolone group improved 4 points by 93 days and the saline did it by 128 days. That did not meet statistical significance. Also, the mean NIS and the NIS lower limb were not significantly different. However, the way patients judged their improvement using Cox life table analysis showed that patients who were on IV methylprednisolone judged their improvement to be significantly better than patients who were on placebo. Also, different measurements in a questionnaire about neuropathic symptoms were significantly better for the first 24 weeks in patients who received IV methylprednisolone. So the use of IV methylprednisolone did not affect the primary outcome measure, time to improvement of the NIS lower limb by 4 points. The possible reasons are it doesn't work, that the NIS isn't a good endpoint, that the study is underpowered, or what I think is probably the most likely explanation, that is the onset of treatment is too delayed. These patients had to be enrolled in the first 6 months of disease. Most of them were getting enrolled right at 6 months, and that tends to be the time at which patients are hitting their disease nadir. Impairment scores in patients with both methylprednisolone and placebo groups improved to a similar extent after enrollment. And this really suggests that an earlier diagnosis is needed, that we're really hitting that disease nadir in both the treated and in the untreated groups. Use of IV methylprednisolone did have a positive influence on neuropathic symptoms, such as pain, positive neuropathic symptoms, and the way patients judged change over time. And I think these secondary endpoints do suggest an efficacy, and pain and sensory symptoms are important, and pain does relate to disability. So we feel that IV methylprednisolone is an effective treatment for the symptoms of diabetic lumbosacral plexopathy, and a treatment trial earlier in the disease course is really needed to answer the question, does it help impairment? We do not have data on the efficacy of IVIG since that part of the study was terminated early. All right, now I'm going to change topics a little bit, but I'm still going to keep this idea of inflammatory diabetic neuropathies. And so we want to look at the incidence and prevalence of CIDP and the association of diabetes mellitus. This was largely the work of my fellow at the time and now colleague here at the Mayo Clinic, Dr. Rupal Laughlin. So, chronic inflammatory demyelinating polyradiculoneuropathy, CIDP. The first large series of this was described by my father, Dr. Peter Dyck, in 1975 when he described 53 patients with what he termed chronic inflammatory polyradiculoneuropathy. Later, the term demyelinating was added. The clinical features were this is a chronic disease more than 2 months. It was a symmetrical disease. It was a sensory motor polyradicular neuropathy, meaning that proximal and distal involvement occurred, and it was a fairly symmetrical disease. And the pathology and the electrophysiology of that disease was demyelinating. Here's a picture from his original paper from a root biopsy showing large onion bulb formation and a brisk inflammatory infiltration into the nerve. Now, diabetes mellitus has been reported to be associated with CIDP. Crendel and colleagues in 1994. Diabetes has been reported to be 20 times more common in CIDP than myasthenia gravis or in ALS. Others have noted that a systematic epidemiological data was lacking. So CIDP incidence and prevalence. Previously published incidence rates for CIDP were 0.15 per 100,000 in New South Wales and in Australia by McLeod and colleagues, and prevalence figures varied from 1 to about 8 per 100,000 in England, in Australia, and in Norway. So the aims of the study were to look at incidence and prevalence of CIDP in Olmsted County, that's where the Mayo Clinic is, residents. We wanted then to assess the prevalence of diabetes mellitus within CIDP to really look at the question, is there an association between CIDP and diabetes mellitus? So we identified CIDP patients and divided into those with diabetes mellitus and those without diabetes mellitus. Diabetes was defined by physician coding, fasting blood sugar greater than 126 on 2 occasions, and 2 non-fasting glucose measures greater than 200. So the classification, to be definite, one had to have 4 of 4 criteria, and that was clinical and electrophysiological, and to be probable, one needed to have 3 of 4, and all the clinical criteria needed to be met. And we wanted to emphasize clinical over electrophysiological findings because diabetic polyneuropathy can have some demyelination on electrophysiological testing, and we wanted the patients clinically to have CIDP. So what are those inclusion criteria? They were a disease course greater than 8 weeks. The symptoms could be slowly progressive, relapsing, remitting, monophasic. The nerve fiber involvement should be both motor and sensory, and there should be large more than small fiber findings. Large fiber are more common in CIDP. It's a demyelinating neuropathy, and larger fibers have more myelin. The distribution should be symmetric. This should be a polyradicular neuropathy, meaning there should be both proximal and distal weakness. And again, this should be symmetrical, less than 25% asymmetry. And only after those clinical findings were met did we look at the electrophysiology, and in there we were looking for demyelination, conduction blocks, temporal dispersions, slowing of conduction velocities, prolongation of F latencies, long distal latencies. Supportive criteria could be elevated CSF proteins, nerve biopsies that show inflammatory demyelination, treatment response to immunotherapy. So we reviewed 1,500 patients who lived in Olmsted County over a 20-year period. 23 of them met the criteria for CIDP. 19 were definite, 4 were probable. There were 13 males, 10 females. The average age was 58 years. 2 of the patients had a monoclonal gammopathy. So the median symptom duration was 6 months, ranging from 2 to 60 months. Half of the patients, 12 of 23, had undergone immune therapy, IVIG, steroids, plasma exchange, or other. So our incidence was 1.6 per 100,000 per year, which incidentally is the same incidence in our population as Guillain-Barré syndrome. So CIDP is as common in Olmsted County as Guillain-Barré syndrome is. It was 1.4 if one excluded the Muggis cases. 11 of the 23 cases had active disease of CIDP and were living in Olmsted County on our prevalence date of January 1st, 2000. So the prevalence was 8.9 per 100,000. So then we turned to looking at diabetes and getting a control group. So we matched 5 control patients to each incident CIDP patient. We had 23 CIDP cases, so we had 115 control cases. They were age and gender matched Olmsted County residents to each CIDP case, and they were registered at Mayo Clinic the year of the CIDP diagnosis, so they would have similar evaluations. So 14 of the 115 control cases were coded as having diabetes mellitus, or 12.2%. One of the 23 CIDP cases was coded as diabetic, or 4%. And so the univariate odds ratio for prevalence of diabetes in CIDP was 0.3, and we did not find an increased prevalence of diabetes in CIDP. We published this in the journal Neurology. So CIDP is more common in our population than previously estimated. Diabetes does not appear to be a risk factor for developing CIDP. Our study is too small to identify a slight association of diabetes with CIDP. The perceived association may be due to a misclassification of some forms of diabetic neuropathy as having CIDP. Now, there was a similar study conducted in an Italian population published in the Journal of Neurology, Neurosurgery, and Psychiatry in 2007. They had 155 CIDP patients in a population of 4.3 million. Their prevalence was 3.6 per 100,000. They had 14 CIDP patients with diabetes mellitus. The expected number was 13 cases with diabetes mellitus, and so they also concluded that there was no pathological correlation between CIDP and diabetes mellitus. I'm now going to talk about a painless motor-predominant diabetic neuropathy. This is the work that I did with Rupa Laughlin and Mercedes Garces Sanchez from Spain. So occasionally we see diabetic patients with severe lower limb weakness without pain and wonder what is the cause of that. There were early accounts of motor-predominant diabetic neuropathies. Chakravarty emphasized the slow evolution with symmetry. Arthur Asbury emphasized a wide spectrum with both rapid asymmetrical disease on one hand and low symmetrical gradually progressive disease on the other hand. Pain commonly occurred in both, but sometimes patients had no pain, and very little has been written about these painless motor-predominant diabetic neuropathies, and so we wanted to look into them in more detail. All right, so Tony Amato and Rick Barron postulated that a painless form exists, much less common than your typical diabetic lumbosacral radicular plexus neuropathy. They suspected that the painless form may in fact be diabetic CIDP, and they suggested that further work needed to be done. They noted that the painless group had not been systematically studied in terms of clinical features or pathological basis. Some studies suggest that CIDP occurs more often in diabetic patients, as we've talked about. Our recent study did not support this association. But if CIDP is associated with diabetes mellitus, one would think it would likely present like this syndrome. That is a painless motor-predominant neuropathy. Now, why is this? That is because CIDP is motor-predominant. Again, CIDP involves mostly large fibers. All motor fibers are large fibers, and so it is a motor-predominant syndrome. CIDP has little pain. Most pain fibers are small and unmyelinated fibers. CIDP tends not to affect those fibers, so most patients with CIDP don't have pain. So if one thought there should be a diabetic CIDP, it should be a motor-predominant painless neuropathy, and therefore this is the good group to look for diabetic CIDP in. So our objectives were to characterize the painless lower limb motor-predominant neuropathy of diabetes mellitus in terms of clinical features, neurophysiology, and pathophysiology. We wanted to emphasize pathology to determine if the syndrome is best classified as diabetic lumbosacral plexus neuropathy, as CIDP, or as its own entity. So we reviewed medical records of Mayo Clinic patients from 1985 to 2005. We identified 470 potential patients. The inclusion criteria was absent of pain, weakness in at least one lower limb, diabetes mellitus, nerve biopsy performed, other neurologic diagnoses excluded, and seen by a Mayo Clinic neurologist. So this was a retrospective chart review series of painless lower limb predominant motor neuropathy. We looked at the clinical, electrophysiological, laboratory, pathological features, nerve biopsies from these painless motor predominant diabetic neuropathy biopsies, typical painful diabetic lumbosacral plexus neuropathy biopsies, and CIDP biopsies were all compared. So we identified 23 patients with painless motor predominant diabetic neuropathy. Half were men, half were women. The average age was 62 years. They'd been diabetic for an average duration of 5.4 years. In 7 patients, the diabetes mellitus was identified at the same time as neurological presentation. All but one had type 2 diabetes mellitus. All right. So we compared our painless motor predominant neuropathy patients to painful diabetic lumbosacral plexopathy patients, the same cohort I presented to you at the beginning of the talk. And a lot of the features were quite similar. They had similar ages, they had similar weight loss, but they did have some differences. The painful form tended to present unilaterally, where the painless form often presented bilaterally. The average NIS score was much higher at 70 in the painless motor predominant compared to the painful, which is 43. And there was much more upper limb involvement in the painless, and there was much more distal leg involvement in the painless forms. CSF proteins were elevated in both groups. So the painless motor predominant tended to be more chronic, where the painful tended to be more acute. As I've mentioned, the painless tended to be more bilateral, where the painful tended to be more unilateral at presentation. Distal involvement was more common in the painless, where proximal involvement was more common in the painful. Nerve conduction studies in EMG showed proximal and distal denervation, large motor unit potentials from multiple different levels. There were mild demyelinating features, but not enough to meet CIDP criteria. Quantitative autonomic testing was abnormal in the 9 people tested, and the average CAS score was 6, which is indicative of a severe autonomic neuropathy. Quantitative sensory testing was done in 9. In 8 of the 9, there was abnormality in both small and large fibers. What did the pathology show? As in painful diabetic lumbosacral plexopathy and painless motor predominant neuropathy, there was evidence of ischemic injury. There was multifocal fiber loss, perineural degeneration and thickening, neovascularization, and injury neuroma. And when we compared these to painful diabetic lumbosacral plexopathy, there were no significant differences. Now, we also looked at a group of CIDP biopsies, and we found these ischemic findings to be much more common in the painless motor predominant biopsies than in CIDP, and there was significant differences in that. In contrast, onion bulbs were common in CIDP biopsies, but were rare in the painless motor predominant biopsies and in diabetic lumbosacral plexopathy biopsies. So here are some examples. Here are some examples of ischemic injury in the painless motor predominant neuropathy. This is injury neuroma, evidence of ischemic injury in the nerve. This is perineural thickening and neovascularization, evidence of ischemic injury and painless motor predominant neuropathy biopsies. Here again, multifocal fiber loss, multifocal fiber loss. This large area here within the arrowheads is an area of injury neuroma and microfasciculation. This is the parent fascicle over here. In one biopsy, there were dense onion bulbs, and perhaps this biopsy really was a diabetic CIDP, but in fact this was very uncommon, and very few biopsies had, only one biopsy had this degree of onion bulbs. All right, we found inflammatory infiltrates in nerves of painless motor predominant neuropathy, diabetic lumbosacral plexopathy, and in CIDP nerves. But the type of inflammatory infiltrates actually was somewhat different. So inflammation involving vessel walls were common in painless motor predominant diabetic neuropathy biopsies. Involvement of vessel walls were also common in painful DLRP. In contrast, involvement in vessel walls were not common in the control CIDP biopsies. Microvasculitis was only seen in painless and painful diabetic lumbosacral plexopathy. Hemosiderin macrophages, again, were much more common in the painless and the painful plexopathies and were not common in CIDP. So here are these inflammatory infiltrates involving vessel walls. You can see fragmentation of the vessel wall with this smooth muscle actin preparation and this inflammatory infiltrate involving the vessel wall in a patient with painless motor predominant diabetic neuropathy. So, what does all this data mean in painless motor predominant diabetic neuropathy? There are some similarities to CIDP. Painless motor predominant is a symmetrical upper and lower limb syndrome. There isn't pain. It's insidious and slowly progressive. Those features are all very typical of CIDP. Saying that, there are many, many more similarities to diabetic lumbosacral plexopathy than there are to CIDP. So, like diabetic lumbosacral plexopathy, there are pan-modal sensory involvement. CIDP usually only has large fiber involvement. There's frequent autonomic abnormalities. CIDP does not frequently have autonomic abnormalities. There's frequent weight loss. CIDP does not get much weight loss. There's microvasculitis and ischemic injury, not inflammatory demyelination as one sees in CIDP. There's primarily an axonal radiculoplexus neuropathy, not a demyelinating process as seen in CIDP. And so we published this in Annals of Neurology. And we concluded that the painless lower limb and motor predominant neuropathy occurring in diabetic patients is really a form of diabetic lumbosacral plexopathy and is painless diabetic lumbosacral radiculoplexus neuropathy. We feel it represents part of the spectrum of DLRPN as opposed to CIDP or a separate entity. Our findings confirm that there is a clinical spectrum in DLRPN as originally proposed by Arthur Asbury. The underlying pathological mechanism of both painful and painless DLRPN is ischemic injury and microvasculitis. Now I'm going to end our discussion today with talking about an upper limb syndrome, a diabetic cervical radiculoplexus neuropathy. This is the work of Rami Massey, and Rami was a fellow at the time when he did this. So the lower limb form, DLRPN, is accepted as being associated with diabetes mellitus. But it's not so clear that an upper limb form, a brachial plexopathy, a cervical radiculoplexus neuropathy, occurs in association with diabetes mellitus. Some authorities, namely Asa Wilburn, have written that they don't believe a meaningful association exists between diabetes mellitus and a brachial plexopathy. So there have been different synonyms for cervical radiculoplexus neuropathy. It's been called immune brachial plexus neuropathy, Parsonage-Turner syndrome, neuralgic amyotrophy, localized shoulder girdle neuritis, acute brachial radiculitis, paralytic brachial neuritis. So Leiden in 1887 was the first to classify diabetic neuropathies into neuralgic, paralytic, and ataxic. O'Shea in 1890 described lower limb in 3 and upper limb in 2 neuropathies or plexopathies occurring in patients with diabetes mellitus. These were cases of intense pain followed by weakness. The deficits improved with time, so they seemed to be a monophasic illness. The disease course was similar between the upper and the lower limb forms, and O'Shea categorized the upper and the lower limb forms together. Bastrin and Thomas in 1981 wrote about diabetic polyradiculopathy and noted involvement of the lower limbs and the thoracic segments together, but they did not have cases where there were upper limb involvement. In our paper in Neurology in 1999, in our 33 prospectively studied diabetic lumbosacral radiculoplexus neuropathies, we noted that 33% or 11 of those cases had upper limb involvement, mostly mononeuropathies, but that 9% or 3 of them had a more diffuse brachial plexopathy. Jonathan Katz in Muscle and Nerve in 2001 had 60 cases of diabetic lumbosacral plexopathy. They noted that 15% or 9 of them had some upper limb involvement, and that 4 of the 9 had bilateral involvement, and 8 of the 9 had hand involvement. So we had some questions we wanted to ask about the cervical radiculoplexus neuropathy occurring in diabetic patients. We wanted to know, is diabetes mellitus causally associated with the development of a diabetic cervical radiculoplexus neuropathy? Are the clinical features of DCRPN different to those of idiopathic brachial plexopathy? Does diabetic cervical radiculoplexus neuropathy occur in association with other forms of diabetic neuropathy, especially the other radiculoplexus neuropathy? And what is the pathological basis? Is it ischemic injury from microvasculitis? Is it inflammatory demyelinating, or is it other? So we did a retrospective chart review of Mayo Clinic patients with diabetes mellitus and brachial plexus neuropathy from 1996 to 2008. 345 charts were reviewed. There were 85 cases, 57 males, 28 females. So the average age was in the 60s, similar to diabetic lumbosacral plexopathy. These patients weighed a little bit more. Their average BMI was 29 versus 26 for the diabetic lumbosacral plexopathies. Their blood sugar control was similar. The duration of diabetes mellitus was similar. The majority of them were type 2 diabetics. 35% of them lost more than 10 pounds in weight versus 85 for the lower limb, so weight loss was less common. They had elevated CSF proteins similar to the lower limb form. So they were both type 1, type 2 glucose impairment. They were on oral agents insulin. Retinopathy and nephropathy were uncommon, and they were fairly similar to what was seen for the lower limb syndrome. The presenting symptom was most commonly pain, followed by weakness, followed by sensory abnormalities. 81% of them had unilateral disease at onset. This is similar to the lower limb form. About half of them eventually went on to have bilateral disease. This was less common, where 97% of the lower limb form eventually had bilateral disease. This was acute onset in 61%, subacute in 27%, and this was more of an acute onset than the lower limb disease. Pain was the most common presenting symptom in 81%. It was hurting, burning, shooting, allodynia. Weakness was common, occurring in 99%. Sensory symptoms were common, and recurrent episodes happened in about 21% compared to 17% of the lower limb syndrome. So overall, the features were quite similar between the upper and the lower limb syndrome. What part of the brachial plexus was involved? About half of the cases had involvement in the upper trunk, about half had involvement in the middle part of the plexus, and about half had involvement in the lower part of the plexus, and overall 30% had pan-plexus involvement. So this is a little different than your typical parsonage-Turner, where the vast majority of cases have upper plexus involvement. It was common to have other nerve involvement than just one brachial plexus. So the contralateral limb was involved in 47%. The thoracic region occurred in 19%. The lumbosacral region happened in 24%, and other in 9%. So it was quite common to have other parts of the body involved. Quantitative sensation showed abnormality in 77% and 10, and that included the vibration, cooling, and heat pain. Autonomic testing was abnormal in 96% of 23 tested. Thermoregulatory sweat test showed abnormality in 85% of the 11 that were tested. So again, this is not a pure motor neuropathy. Sensory and autonomic systems are also involved. Nerve conduction showed an abnormal motor response and abnormal sensory response. Demyelinating features were uncommon. Fibrillation potentials were seen in 94%. Paraspinal abnormalities were not as common in the lower limb, occurring in 32%. Nerve conduction studies, EMG, were consistent with a predominantly axonal process that was more widespread than was apparent on clinical deficits. Now, we did some imaging in these patients. 38 of 38 patients showed some form of imaging abnormality. Now, this might be increased T2 signal in 96%, nerve enlargement in 67%, nerve enhancement in 19%, increased T2 signal in 46%. And I think another important point is that we often want to categorize disease as occurring at the root, occurring at the plexus, occurring in the peripheral nerve. There's abnormal findings in the brachial plexus in 98%, abnormal findings in the cervical roots in 72%, abnormal findings in the peripheral nerve in 70%. And so I think this really confirms this idea that it doesn't respect the boundaries that we have created, and that the roots, the plexus, and the nerves are all involved, and these conditions really are radiculoplexus neuropathies. They involve the roots, they involve the plexus, and they involve the peripheral nerves. So here is an MRI showing the cords of the brachial plexus being hyperintense. There's also some denervation of the infraspinatus muscle there. Here you can see the cords of the plexus with no enhancement, mild enlargement, and again some denervation. The pathology of this condition was compared to diabetic lumbosacral plexopathy nerves. On teased fiber, we showed increased rates of axonal degeneration, and this was quite similar to what we saw in the diabetic lumbosacral plexopathy nerves. So here are examples of widespread axonal degeneration. We found evidence of ischemic injury. And these are nerves taken from the upper limb. There was multifocal fiber loss, perineural degeneration, perineural thickening, new vessel formation, injury, neuroma. And when we compared these to nerves of diabetic lumbosacral plexopathy, the findings were quite similar. So here you can see multifocal fiber loss typical of ischemic injury. There were inflammatory collections, small, moderate, large collections. In 8 of the 11, there was inflammation involving the vessel wall. In 5 of them, there was microvasculitis. There was evidence of previous bleeding with hemosiderin. So here you can see both evidence of large vessel involvement and microvasculitis. So here in this large arterial, there's fibrinoid necrosis, but in an adjacent vessel over here, you can also see an inflammatory reaction involving a microvessel with involvement of that vessel wall. Here from other nerves, you can see microvasculitis, inflammation throughout the whole vessel with fragmentation of the smooth muscle actin. These are the same vessels here. Here is a level that's not involved, and here you can see fragmentation of the vessel. This shows you hemosiderin-related macrophages in blue around a blood vessel. So the vessel's been damaged and it's leaking blood out and it's turned into hemosiderin. So, for diabetic cervical radiculoplexus neuropathy, we feel that this is a subacute, monophasic, painful neuropathy beginning unilaterally in the upper limb and sometimes becoming bilateral. It has many clinical features similar to diabetic lumbosacral radiculoplexus neuropathy. It's not a pure motor syndrome. Sensory and autonomic fibers are involved. The pathological basis is ischemic injury from microvasculitis. that occurs at the roots, the plexus, and the peripheral nerve. Diabetic cervical radicular plexus neuropathy is part of the clinical spectrum of diabetic radicular plexus neuropathies. All right. Well, thank you for hanging in there with me. I've now done discussing diabetic inflammatory neuropathies. I feel that diabetic lumbosacral radicular plexus neuropathy and diabetic cervical radicular plexus neuropathy are part of a broader category of diabetic radicular plexus neuropathy, or DRPN. The DRPNs are monophasic illnesses that begin focally, usually with pain, and evolve into more widespread diseases with weakness. The DRPNs are due to ischemic injury from altered immunity and microvasculitis occurring at the roots, the plexus, and the peripheral nerve levels, and it doesn't respect one of those levels. It goes through and involves all those levels with different degrees in different cases. A controlled study of IV methylprednisolone in diabetic lumbosacral radicular plexus neuropathy did not affect impairment, but did improve many of the sensory symptoms. Diabetes mellitus and CIDP are probably not causally associated. Painless diabetic motor neuropathy is a form of diabetic lumbosacral radicular plexus neuropathy and is not diabetic CIDP. Inflammatory neuropathies, especially those with asymmetry and subacute onset, can occur in association with diabetes, especially type 2 diabetes mellitus. And I want to thank all the different people who worked with me on this. This is largely the work of Rupal Laughlin, Rami Massey, Mercedes Garza Sanchez, the different histology technicians, especially Janine Engelstead, data analysis, Dr. Robert Spinner is a neurosurgeon who took a lot of these biopsies, Kim Amrami, who's a radiologist who helped us out. And I'll take any questions now. Thank you very much.
Thank you very much, Dr. Dyck, for this excellent presentation of the different phenotypes and some pathophysiological aspects of the diabetic neuropathy. At this time point, the participants in our webinar start to ask questions, and the first one is Dr. Uncini from Italy, who is now visiting professor at our center, who would like to ask a question.
Hello, Peter. Thank you for this great work you have done in the field, that we really appreciate. You insisted a lot that both diabetic lumboradicular plexopathy and also cervical lumboradicular diabetic plexopathy are not just motor. But it's a clinical experience of all of us that when you visit them, they are motor predominant or motor exclusive. So the question is that because our clinical tools are poor in documenting that, or just because sensory fibers are more resistant to ischemia than motor fibers?
No, I think it's a good question. So I would agree with you that I think these syndromes are motor predominant. And certainly that is what has historically been written. I do think that at the Mayo Clinic we are very fortunate that we have nice quantitative sensory, autonomic, thermoregulatory sweat test that most of the world doesn't have access to, so we can identify more subtle abnormalities than other people can. But I do think it is important to recognize that these syndromes are not pure motor syndromes. And in fact, I think clinically, you know that too, because these patients usually have a lot of pain. Now, of course, I presented a form that's painless, but they usually have a lot of pain. I think it's a very important question why they are motor predominant. You know, are motor nerves more susceptible to ischemia than sensory nerves? I don't know if I know that, but certainly I agree with you. They are motor predominant, and that is an important clue into their pathophysiology. I think all the pain they get is also an important clue, and I still wonder why these painless forms don't have pain. They seem to be more insidious. So is it the fact that the ischemia is occurring more slowly that they don't have pain, and that's the more insidious course is the reason they don't have pain? I think there's a big clue there too, but I don't claim that I understand that.
I have a question regarding the diagnostics in the clinical routine, besides of research issues. Do you recommend nerve biopsy in every of these patients, or mainly for research purposes?
I think that's a very important question. So should you biopsy everyone, and what is the purpose of a nerve biopsy? So I think at the Mayo Clinic, we use nerve biopsy in clinical practice. In fact, I don't think any or very few of these cases were biopsied for research purposes. These cases were all biopsied for clinical purposes. We biopsied them to understand their disease to help us figure out how to treat these patients. Saying that, you certainly don't need to biopsy everybody, and I don't biopsy everybody. So I tend to biopsy cases in which I think there are atypical features. Maybe they're happening quickly, and I'm concerned about other pathophysiologies. For instance, I've had cases of what look like diabetic lumbosacral plexopathy that end up to have neurolymphomatosis. And again, there are other features that go along with that. Do they have B symptoms with night sweats and things like that? Do they get concomitant cranial neuropathies? Is it a progressive disease even after I've treated them with IV methylprednisolone? Things like that would make me be concerned about it and go after biopsies more. Another part about the biopsy, which we didn't talk about at all in this talk, but is that I do both distal cutaneous nerve biopsies, such as a sural, a superficial perineal, or in the upper limb, a superficial radial, but also with the use of MRI, we're increasingly doing targeted fascicular nerve biopsy, where we use a high-resolution MRI scan, and we do a sciatic biopsy, where we do a fascicular biopsy. We take a bit of the nerve and leave most of it behind. So the answer is most of the cases I don't biopsy, but I absolutely use the biopsy to help treat the patient and guide the treatment for the patient.
Okay, thank you very much. Now we switch to Geneva, and we will take questions from Geneva. Are there any questions from there?
Yes. Yes. Thank you very much for this very interesting overview. I have a question. Have you an idea of what can be the trigger of this monopathic condition, of this vasculitis? Is this, for instance, a drop of glycemia or something like that? Or are there some means to prevent this condition?
Now, I think the question of what is the trigger of these conditions is an incredibly important question. And I think there are different triggers. For instance, we have published, subsequent to these papers, what we call post-surgical inflammatory neuropathies, in which we identified a cohort of 20-some patients who, after surgical procedures, developed oftentimes radiculoplexus neuropathies. And many of these patients are diabetics. And so the stress of surgery, and we've done nerve biopsies and shown the same pathology, microvasculitis and ischemic injury. So in some patients, surgery can be a trigger. In other patients, they find out that they are diabetic. They are overweight. They don't do exercise. And so they have a religious conversion. They start exercising. They start eating healthy. They use insulin. And in this context of doing all of these things, they start losing a lot of weight, and they feel really good about themselves. And then they can't control the weight loss. And it continues on, and they develop pain and weakness in the lower limb. And clearly that seems to be iatrogenic and induced. I have a patient who was a physician who was overweight and was put on in the hospital on a starvation diet and put on an insulin drip, and that induced a diabetic lumbosacral plexopathy. So I think too rapid shifts in blood sugar levels is one form of a trigger. Now, there's a completely different literature, but I think is quite pertinent to this, that's come out of the Joslin Clinic in Boston, Massachusetts, and that's on this insulin neuritis. And again, I think that's a trigger for these sort of things. So they talk about treatment-induced diabetic neuropathy. Those tend to be type 1 diabetics. And in these patients who get put on insulin, and again, they have rapid shifts in their blood sugar levels, they tend to develop a painful autonomic neuropathy. It's not a weakness neuropathy, but it's a different cohort. It's more the type 1s. I think that's an inflammatory condition as well that's triggered by too rapid shifts in blood sugar, and I think it's a cousin to the conditions that I've been talking to you about today. I've talked to Chris Gibbons, who is the principal mover in that, and they haven't done nerve biopsies in those patients, and I would really like to see the pathology in some of those patients.
Okay, now we go to Lausanne. Are there any questions from Lausanne?
Okay. Gunther from Lausanne. Hi. Thank you very much for your presentation and discussing your data. I have a question about new potential treatments in these focal neuropathies. Do you think that rituximab may be useful in those patients?
So is infliximab useful to these patients? And the answer is I don't know. I haven't used it. I think many of the newer agents might be useful in these patients. I personally have used steroids. I've used IVIG. I've used a couple of cases plasma exchanged. I've used Cytoxan. I've found all of those agents to be useful, but I haven't used other agents, and so I can't answer the question. But it certainly might be useful.